going back since the 70s. A graduate, of course, of the 69 batch, finishing sometime in the mid 70s. But the important part of that comment was really the influence that people like Dr. Louis Montero, C.M. Francis, had on some of us to be very involved with the mission of St. John's, of working for the community, working for public health with public health in mind. And I was very fortunate at that time to also have people like Major General Mahadevan and S.P. Ramarao, who were so committed to public health and training of students with that in focus, not just preventive medicine, but very much an integral part of the holistic medicine. And further, it was an opportunity to work in community health centers that we developed, not only for our own training, but for the outreach program in Malur, in 5 centers around, I forget the very names of that, in the primary healthcare centers for training of students that we developed. And then came the opportunity as we were developing this with people like Ravi Narayan, Dara Amar, and other colleagues in the department, where Ravi had been to the London School and the Ross Institute of Occupational Health, where he went for his master's program and really came back with ideas of how to move that whole concept forward in the department. And we were in constant touch. I was in constant touch with him while he was away. He is, as you know, a master of engagement of staff and students, and we were very fortunate to be part of that journey with Ravi and subsequently with Dara and the others. Uh, Having said that, the question was, what does Ross Institute do in in uh, in India that they did not do or could not finish in what they had started for many, many years before that in the plantation coffee and tea, coffee plantations in particular, and tea plantations in the Assam mountains, Assam hills. The reason why they were in that region, which you might have already heard from Ravi, was because the Ross Institute wanted to make sure that they looked after the medical officers of health uh, who were working in their plantations of the owned by the British at that time, eventually taken over by the Tata plantations. Uh, but they wanted to control malaria. And malaria was, in the course of time, as you well know, came under pretty good control. And the contributions from the plantation medical office, plantation owners, etc., started to diminish quite dramatically. So when many of us put our heads together as to how to help Ross Institute uh, put a seed back again in India, the question became pretty obvious to some of us. They had to have an academic base, and that academic base was probably a good thing to have at St. John's because Ravi had been there, Dr. Mackay uh, um, and Professor Bradley at the London School felt that this was a good suggestion, so they had come over. And we felt that the plantations so making it rooted in having it rooted at St. John's in the department of what was at that time preventive medicine was a natural. And with that, there was tremendous support from Dr. Louis Montero and subsequently with Dr. Francis. And it was obvious that we could do this. The question is how. And how do we keep that tradition of occupational health, but and and working with the plantations? So some of us went and visited the plantations in Munnar to start with, and subsequently along all the hills. I forget the names, right up to the Nilgiris and Coorg. Uh, Met with some of the plantation medical officers, and we've had a wonderful lady who was the president of the association at that time, Dr. Ramatullah. she was just a dynamic person. Dr. Ramatullah was um, the she would not take no for an answer. There was a great bond with her as with all of us, and we came up with the idea that one way to get ourselves implanted in the coffee plantations, if I may use the term, was to actually start training of the medical officers of health with the purpose of not only improving occupational health in the plantations, but it was overall public health and preventive medicine. So between Ravi, Dara, and myself, Telma Narayan, Ravi's wife, subsequently also came into the picture, and together with some other wonderful people like Gopinath, if I recall the name, and I forget the names of Radhika Nambiar, who was all supportive staff, and many other people. Joseph, I forget his second name again, but all people who helped with the balance of occupational health, training of the students, and community health, but at the same time, all the field exposures that we created in Munnar. What was great is that as part of the training for students, but also as part of the training for the lectures, etc., for the medical officers of health that we brought in, we actually engaged all people, all the many professors in the faculty itself, not only people from the community medicine department or preventive medicine department, and but also from others. And also the good news was that both Major General Mahadevan and Ramarao, Major General, before he came, he was, of course, as the name said, Major General Mahadevan. You had He had exposure to occupational health as part of his background as well, uh, if I'm not mistaken, and so did Dr. Ramarao in preventive medicine. Just amazing mentors for many of us. There was incredible support that I forgot to mention. I am remiss in not mentioning her earlier. Is before Dr. Ramarao and before Major General Mahadevan as well, is Dr. Marie Mignon Mascarenas, um, who was the professor who started it all, actually. And I apologize. I have to go back and correct my sequence of events. Dr. Marie, who unfortunately has passed away, with tremendous support of her husband, Dr. Alfred Mascarenas, who was the surgeon in at the hospital. All of them, especially Dr. Marie Mascarenas, was very involved with helping Ravi and myself to set up, and Dara to set up this occupational health department. So I think kudos to her for having that vision and openness to work with. She was just an amazing networker. There was nothing that she could not put things together. So she was incredible. The reason why I mentioned last time Ross Institute was looking for an academic setting was because when they finished malaria eradication campaign or programs, and malaria was under control in the tea gardens in Assam, the question was how to make it a program which would actually continue if there was the funding would became an issue of a particular program if we did it straight in the plantations itself. And having an academic setting uh, would actually be helpful and useful to do that, because it would also provide for an opportunity to train the future physicians, interns, etc., that St. John's was rapidly developing as a program. But in the process, Ravi and I and Dara Amar, Professor Ramarao, Major General Mahadevan would all start to include occupational health lectures and training for students. We would make sure our students and residents would all be exposed to occupational health as part of their training. We felt at that time that the work that we had started in Malur, etc., had to continue, but also there was a tremendous amount of interest that that um, the London School and the Ross Institute showed in the work that we were doing with the plantation medical officers of health, whom we felt should be actually trained themselves in public health. Besides being good doctors, they had to have the preventive medicine, occupational health training to continue if this was going to be sustainable. And those rotations used to be about a month or 2 months, if I recall. And some of the interns opted to actually do longer stints of working up to 3 months in the plantations. So, so that was Upasi's role at that time, and we also used that for Dr. Ramatullah and the others to come and speak to our students who were part of the preventive medicine training program at St. John's, even though they may not have been involved in the occupational health. But occupational health became an integral part of our teaching of the students as well when we were at St. John's. So sometimes we would invite them to come and share their experiences of what it was like to work in the plantations, and we would, of course, use our experiences that we had in the plantations to teach our students as well, both Ravi, Dara, myself, and all of us. The principles of occupational health and the work that we were doing across the country very much linked to what the academic institutions had to offer, both from the Ross Institute in London, the London School of Tropical Medicine, St. John's, and other institutions. But St. John's was one of the pioneers in this area, and Ross Institute was a very integral part of that. And to inculcate into the minds of students, our interns, etc. So we started working with them, and with the help of our interns, etc. We started to doing surveys of major causes of morbidity and mortality. Um, we found high rates of anemia in pregnant mothers. What was the cause? It was really hookworm that was causing severe anemia. So obviously the question was, how do we provide that intervention? And what became obvious as well is that the water was not chlorinated. The question was why? Why did the doctors not do that? And at that time, it was because of the pressure of the water coming down the hill could not maintain the chlorination by the time it went down. There was no way to control it at that time because the water had to be broken in terms of speed, not just going down the pipes with the chlorine. There was no chlorine left in the water down. So we came up with a concept with an engineering firm right outside in Koramangala as the development was happening with something called a shunt feed chlorinators, if I recall. And that helped us to actually break the speed of the water as it came down without building large tanks. And when I went last with my classmates for an alumni meeting, and I think that was about 15 years ago, I went and visited the shunt feed chlorinators we had actually put there, and they were still working. I don't know how. Pipes would have been rusty, of course, but yes, they were still working. But the interesting thing is that within a year, we found the dramatic decline in hookworm disease in mothers. We found much less miscarriages in mothers, so that we were onto something. So that work continued, and I do not know whether it still is now how the water is chlorinated, but that still was very helpful. The second thing that became obvious as we started to study the problem, as we visited the factories for the coffee gardens, it was obvious that there was severe amount of redness in the eyes, severe cough. People were reported as being sick because of severe cough. Uh, and one thing became very obvious, how that it was easy to actually control this. So we had said, let's make sure that there was a reduction in different ways of equipment and so on and so forth. But the simple way was actually masks to avoid the dust. There's a tremendous amount of dust during the coffee development process. And introduction of those masks really already had helped uh, quite dramatically. The severe redness of the eyes, severe cough, asthma, etc., that were being reported in the hospitals already. So those were primary care preventions that were very helpful. Now, use of those masks came on way before COVID, of course, over there. So that was very helpful, and I hope that it was helpful during COVID for them. This kind of work kind of started to spread, and some of us were very involved in Malur as part of the occupational health work and training on what we were seeing in the clinics on a daily basis, morning to evenings, patients coming for the primary care setting in clinics that we had, again with severe redness of the eyes, severe cough, problem with chronic obstructive lung disease. And many of us started to study that particular work, did the work, and obviously it was not so clear for a while, but then it became very clear that there had to be a common origin. So it was mostly people who were working at that time in the silk industry. Malur, as you may or may not know, is a big center for the whole area around Malur for collecting of the silkworms to make silk for the beautiful saris that everyone wears and silk clothes that everyone wears in India. So some of us started to study the that work, and I was one of those who actually led that particular work in the beginning, and fortunately it continued after that with other interns, etc. But what became obvious when we visited those silk factories, or they were cottage industries, not big factories. They were cottage industries that people would collect the silkworm from and undo this from the cocoons, take out the silk fiber, and then reel it on to reuse. But in the process, to kill the silkworm, you had to actually have very warm, hot boiling water in big pans. And those big pans actually were boiling water where the silkworm, the cocoon would be put in. The poor silkworm would, of course, die, and the thread would be unbound onto silk reels. And that helped. I'm sure if you look at the old records, you might find some of those pictures, and if not, I might be able to find some for you. But that was what began the journey to understand and train some of our residents in occupational health as well, another aspect of that. And that was because what I did at that time was to actually try and start with wearing masks again, and but also glasses or goggles for people who were working. Now, the problem that they also had was that they had red eyes and severe redness and conjunctivitis type of illnesses. They had coughing episodes, obstructive lung disease, but they also had severe dermatitis. So I was trying to figure out what would be a common cause that would explain all the three. So I did pick up the couple of worms, couple of cocoons, samples of water from those buckets, and actually sent them to an institute in Delhi for occupational health and biochemical examination. And we found, interestingly, that in the water there was a substance that when the worms were dying, when the cocoons, with the worm in the cocoon was dying, you had a substance that the cocoon would release called sericin. And sericin was a protein which was actually has subsequently I found that they had quite a lot of amino acids, and that water in that it was filled with those amino sericin, and those vapors were then irritating the eyes, causing irritation of the lungs, and that then became an interesting series of work that I did. But we would not usually go and lobby the government ourselves. To the best of my knowledge, I don't remember doing that myself, but we would work with government officials whom Upasi would bring together for meetings or for conferences and so on and so forth. Within Bangalore, for example, working with the Occupational Health Association in Bangalore, that was something that we worked with, but they would actually bring the government people, etc., together. Uh, Within the India scene at that time, it was more through conferences, etc., that were organized by by India Association of Occupational Health, wherein we would present our findings and they would take our we also then felt the pollution that was happening was an important element for us to think about way before I think a lot of the environmental push started to happen. And I happened to participate in in Bombay at the occupational health meeting and jointly done with the Tata Institute for Occupational Health or something like that. I forget. It was way out in Chembur in in uh, in Bombay, and that's when we met some very nice folks who were ready to help us with some of the occupational health work that we were doing. Of course, we were doing this on a shoestring budget. When I think about that, work that we would get, and Ross Institute was as generous as possible, and of course, so was St. John's to help the department. But they gave us the equipment to help set up an occupational health little lab to be able, which is on the other side of the Department of Public Health. I don't know if it still exists, but in that other corridor. Uh, and that's when we started the occupational health lab ourselves. And that's when we had some equipment that would enable us to start to collect air samples from different parts of the city, different parts uh, of the plantation, so on and so forth. And those samples that we would collect on like a filter paper would then be actually sent to the institute in Bombay to be able to monitor what the pollutants were at that time in and around St. John's or certain areas, etc. So we would send that to them, and they would test it and send some of the results back to us, and that eventually also helped us with some of the work that we did, and we organized a meeting with them in Chembur in Bombay for occupational health uh, uh, and shared our experiences with them, uh, how we were doing our occupational health work, so on and so forth. And that was just an attempt to to popularize, so to say, some of the work that we are doing and make it known. Our lab was in some ways a very rudimentary lab when you think about that. But that was because the funding that we received uh, was not a lot of funding, but the London School did help, Ross Institute did help us, St. John's did help us, but at the same time, we also had to depend on the support that we got from the Atomic Research Center, if I recall, Baba Atomic Research Center, of interest in contributing to improve knowledge, as I said. So the equipment that we had was much more to be able to, to not necessarily to do a lot of research work, but also more practical and for training. And on second, I mean, if you had a lot more funding, there would have been better equipment, etc., to train staff and students and do more work. We didn't, neither did we have a lot of staff to do that, but neither did we have the resources to expand on the labs. I do not know whether, do you know whether the lab has been expanded at that since? Have you visited the lab in the?
I don't
No.
think the lab has been expanded.
Okay. 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 It's literally on the other side of the department where we started a little. where even my office used to be at that time. It's on the other wing. It's on the other wing. But the research, as I mentioned, was much more field oriented, as uh, whether it was in the coffee plantations or it was in Malur or other places, or collecting environmental samples wherever we went and doing some testing ourselves, or doing the water supply testing and things of that nature. But what became very obvious is that the medical officers of health themselves, who were wonderful doctors, but they lacked public health perspective and training. So a lot of our interns went there, but we also felt we should give an opportunity for the medical officers of health to be trained on a formal basis for a good period of 10 to 15 days. So we, together with Dr. Ramatullah, we organized training for them in St. John's. We brought them all to St. John's. That was all paid for, their travel, etc., by Dr. Ramatullah and the Association for Medical Officers of Health through the plantation uh, funds. But we also paid for some of the work that was done through the Ross Institute, organizationally, and for all our times, etc. Dr. Mahadevan, Ravi, myself, Dara all spoke during this presentation. We gave them lots of materials to take back with them, and that was considered very helpful and very useful as well. We also went there, Ravi and I in particular, to give lectures over there. And whenever Dr. Mackay would come, and he would come very conscientiously every 6 months. The good thing about the program was it was very community health, occupational health principles based. So it was not just didactic lectures that one would give. We would choose topics of importance to the region, to the area, from simple, and we would actually work with them, with Dr. Ramatullah, etc., to get a feedback early on, at least input, as to what are the topics of interest to them rather than us in our typical, otherwise, ways of functioning, of doing things that we thought was important to them. And I think what was appreciated is that the curriculum for the seminar, sometimes they would last for a day or two, or sometimes for three days, or 4 days, or a week, when we would bring them to St. John's. But I think it would be more when we went there in particular, or otherwise, we would take things, simple things, like as I mentioned to you, how can we address this problem of hookworm by chlorinating the water? But that required surveys in the field, that we would find out what was the cause of uh, at that time, and come back with solutions, or at least think of solutions together, like the shunt feed chlorinators that I mentioned, that we developed in Koramangala with the engineers, and we took him along with us to show how that could actually break the speed of the water coming down from the mountains, and then create an opportunity to have a constant delivery of chlorine of parts per million, so many parts per million, or 1 parts per million, if I recall. So that was possible, had dramatic effect. So he would come and help us to set up those sulfate chlorinators, and the management would actually pay for that. The coffee and tea garden management would pay for that. But developing curriculums based on what they needed and what we would teach them, but also they would share their own experiences with each other, not only ourselves, but also teach our students and ourselves. All along, it was always a learning opportunity for all of us. Also, when they came, we would occasionally expose them in groups to some of our healthcare centers, whether it's Malur or other places, where they would see how primary health care was delivered within an academic setting as well, and how they could be trained. And that would be certain medical officers of health were more academically oriented than the others, and that was fine. That was fine, and those would be picked up to be the coaches for the others as well. And Dr. Ramatullah, as I mentioned to you before, would always be a wonderful coach for them too, and for all of us. But they have wonderful workers, but they did not really have good occupational health practices. So to get into the factories, to be able to identify what caused those problems that they had, the respiratory problems, uh, we needed help from the Upasi management, from the management of the factory. So for that, you needed the Upasi management permissions to get in there, to work, etc., to get the trust to do work in the plantations, right down at the bottom of the hill, to talk to the workers, uh, to see what was the problems, how we could address those hookworm problems, anemia problems, lost pregnancy problems, issues, etc. Chlorination of the water supplies to provide clean water. You needed Upasi members' help from the plantations. You needed the permission because they were very sensitive to people going and talking to the workers about poor living conditions, about 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 sensitizing them, if I may use the term, of the fact that they were not being they didn't have the best conditions for healthcare and so on and so forth. So it was always challenging. We always have somebody accompanying us and keeping an eye on what we were talking to to the people who were workers, taking their pictures, etc. So that took some time, and but when the trust was built over the years, it was easier and easier when the medical officers of health knew that we were all supposed to be working together on this, and the plantation management knew that we were there to assist as well. So the question of trust was useful. When we organized symposia, when Dr. Mackay came, for example, we would have seminars and symposium in the plantations itself, as part of the teaching of the medical officers of health. Or we would arrange training in St. John's and would be bringing medical officers of health from there on staff from the plantations to St. John's. Sometimes being able to coordinate it with Dr. Mackay would be visiting us in St. John's to share his experiences, which were tremendous. I mean, he worked in Africa, he worked in Sri Lanka, he worked in many other British colonies, and he worked in Assam for a while. So he was just a wonderful person to have around. So that was Upasi's role, and thanks for reminding me. That was a very integral part of some of the stuff that we were doing, because we were finding ergonomics has always been an integral part and of occupational health. Of course, it has really taken off subsequently in the uh, latter part in the 90s and 2000s and beyond, of whether it is the posture with which the workers have to work, the number of breaks people have to have, the repetitive movements that people have to have or had to have. And it's all well and good when you can have the luxury of getting some nice chairs to sit on, or, uh, or, whether you want to stand up and have upright tables today to work from, as opposed to just sitting down all the time. The postures for your back in particular, or for typing, and supports for the wrist for constant recurring injuries. So that was something that we did take into account. We did teach as part of the student program, but also we shared those thoughts and with the medical officers of health for training as well. Or we would get people from there to actually start to identify in the plantations, for example, what was some of the reasons why people were having back pain and so on and so forth. Also falls, floors, floors that was slippery, etc., because of rainy conditions, how to manage and stop those falls by having different kinds of flooring. Yeah, so all that was very an integral part of some of the training. Did we do a great job on that? Maybe we could have done much more at that time. Uh, but we did use people where, whoever we could find to help train and so on and so forth. The other one was in Bangalore Association itself with the BAL, Bharat Aeronautics Factory, I think it was BAF, I think, close to the airport at that time. And we had a wonderful medical officer, medical director at that time who was very helpful. And together with that, we helped to coordinate an occupational health meeting uh, at which we presented some of the work that we were doing, but also the work we had done in Malur on occupational health amongst silk workers, amongst the sericulture industry, as we used to call it. So the solution was not so difficult. It was, again, wearing masks, but also wearing gloves. But to understand what simple solutions are not always very welcome, wearing masks, as I explained earlier, for 12 hours was not something that was welcome. And wearing gloves, so it required a lot of education, lots of supervision, and lots of gentle nudging. But at the same time, wearing gloves was difficult for workers because they needed the fine tactile sensations to unravel the thread from the cocoon to put it on the reel and keep it moving in the hot water. So there was severe dermatitis that many people had because they were working in hot water all the time. So we wanted gloves on their hands, but how do we manage that tactile sensation? So it was a lot of, they themselves trained to wear gloves and still managed to do their work, but it definitely stopped the dermatitis that they were exposed to. So these are simple examples, simple things, and working uh, around. And I think that was appreciated. Simple solutions to what appeared to be more chronic problems. That the principles of public health and community medicine very much could be translated into the occupational health setting. And that translation always stayed with me, for example, in whatever I have done since, because I have devoted my life to, after coming here to Canada, along the same lines, but not in occupational health settings, but in public health epidemiology settings, government policy settings, and so on and so forth, but more dedicated towards vaccine development, vaccine clinical trials, etc. Though they are slightly different, those principles of public health and epidemiology training, uh, which could be applied within London School, within Ross Institute, St. John, all kind of stayed with you for life in some ways. Whether it was polio eradication work that I have been working, smallpox, a history that I have written in development of newer smallpox vaccines and newer polio vaccines, meningitis vaccine, all these principles of public health, epidemiology, clinical trials have helped me in what I'm doing even till today. An element that was applied, but this was things that I took from there, but also when I was doing my post-graduation and being a lecturer in Sevagram in Mahatma Gandhi Institute of of Health Sciences in Sevagram near Nagpur. It was a institute started by one of the lady doctors, Dr. Sushila Nair, who used to work with Mahatma Gandhi. She was the dean, and she started this very community health oriented institution where I opted to go for my post graduation in community medicine. And during that time, we worked with a group called Medical Friends Circle, started by couple of people from Gujarat, Dr. Abhay Bang, who was from Nagpur, Dr. Ulas Jaju, who was from there. These are names that might not mean anything to you, but Ravi Narayan, Telma, everyone joined subsequently this particular group. And we were looking at simple things like this for across the country, and the group was working on issues of that nature. And Lathyrus, as we worked, we looked at the problem of severe paralysis amongst people who are working uh, to grow Lathyrus sativus for farmers as bonded laborers. So we did a huge survey in many places, and we would spend a couple of days and sometimes a week going around uh, trying to find out what was the cause of this uh, disease, very much like the Hadigundu syndrome because of contamination of chemicals in the waters near Mangalore at that time, near Chikmagalur. So this was epidemiological work that we did, but also education, training, trying to have different ways of growing the Lathyrus sativus, etc. That was a more conscientization element of work that was done. But they were in principle both public health and occupational health issues. And again, that became a very nice thing to teach students. In this case, it was more teaching students in public health in Sevagram at that time. But people who came for meetings, trainings, took it back to other places in the country for their own medical institution to instill. So, but we would share, I would share, Ravi would share our experiences in occupational health at the Ross Institute with this other group of physicians, where we would uh, share our thoughts and very grassroots movements in medical, called the Medical Friends Circle. So I think that was, if you look it up, I'm sure you may or may not find it, but I'm sure Ravi and Telma can explain to you as well.
So, yeah, I just want to say one thing. So this meeting is about to get over because of the thing. So I will send you the link for the.
It was instrumental. It was a time when Alma Ata conference of primary care had happened in Tashkent with our Prime Minister Shastri, who was there at that time. And there was a lot of movement, more interest in primary health care. So my thesis was actually for my post-graduation is study of primary healthcare workers in different parts of India, which I had the opportunity to visit over 6 months. So collecting of that data, uh, grassroots levels in the mountains in different settings uh, where primary healthcare was offered both in the government primary healthcare centers, but also NGOs and other places. So that formed the basis of my thesis of understanding and helping to form policy for which Dr. Sushila Nair, as a Minister of Health, then took and presented some of the findings to the government in Delhi at that time. It was an early time for primary healthcare reviews and implementation of the Tashkent findings and uh, and require kind of need to move forward with the agenda in India as well. And that's where also some of the work that we did with Medical Friends Circle, working with communities, taking students to the communities, etc., kind of continue. But again, her philosophy and her work, she was instrumental in also influencing my thoughts, my thinking of how she thought of healthcare, not just a very very highly sophisticated institutions, but how young doctors have to move out of the ivory towers into the community and so on and so forth. Slightly less of a Ross Institute occupational health uh, focus as such, but in general, it all comes together.